Well, let me go back one here. All right, so welcome everyone in. Kind of a fun start this morning as we get into our session. Thank you for joining us today for another Great Lakes ROTA-RC presentation. Today we're talking about widening the aperture, the Swiss cheese model for opioid policy. I'll be introducing our presenter here in a moment, but I just need to go through a few housekeeping items to get us started this morning. My name is Amanda Kura. I'm the ROTA-RC Regional Project Manager, and I'll be your host today on behalf of University of Wisconsin-Madison Extension. We are a SAMHSA-funded project. We cover HHS Region 5, indicating those states you see listed on the screen. We do have our website there. So let me just take a minute to show you some of our products so that you can make sure to get connected with us after today's event. We do encourage you to check out our website. We have more opportunities for virtual education, both through the Technical Center and through our partners. You can get connected to our newsletter, a request for technical assistance, and we generally try to make it a one-stop shop for just getting connected to what's happening in substance use and mental health for our region. This is a brief snapshot of our newsletter landing page. You can get previous articles, get signed up to get new newsletter articles. We encourage you to follow that as well because we do prompt twice a month, upcoming training events, and just learning opportunities. With that being said, let's go ahead and get prepared for our session this afternoon, depending on where you're sitting. ROTA-RC does promote the use of affirming person-first language when we're talking about behavioral health disorders. We encourage everyone in creating a space of community collaboration to use non-stigmatizing, recovery-oriented language that can really help reduce that negative bias and promote successful engagement in treatment and recovery and learning. So with that being said, welcome in one last time to Great Lakes ROTA-RC. We're happy to have you in our virtual learning community. I'd like to turn now to welcome our presenter, Dr. Jonathan Stoltman, who is the director of the Opioid Policy Institute. He's going to be talking to us today about our core topic. With that, I'm going to go ahead and stop sharing and give it over to Jonathan.
Awesome. Thank you, Amanda. Let me just do this. This will stop your screen sharing. Yes, I'm allowed to do that.
Yes, you are allowed to do that.
Swap it. Awesome. Okay. So thank you everybody for taking the time this morning. Really excited to talk about this topic. It's a new one for me. I first presented it at Wisconsin over in May. But always open to questions or comments, so feel free to drop things in throughout. You can always also reach out to me through email or through the opioidpolicyinstitute.org if you have any questions or would like any support around this or other opioid-related topics. All right. Just a little bit about me. So I have my PhD from West Virginia University. And sorry, this is like, okay. I have my PhD from West Virginia University, and I've been doing opioid-related research and advocacy for over a decade now. Like Amanda said, I'm director of the Opioid Policy Institute. I also am co-director of Reporting on Addiction, a group where we help journalists cover drug use and addiction in a way that is reducing stigma and bias towards people with drug use and addiction. Then I'm also assistant professor of Michigan State University. Very happy to see someone from the Sioux on here. It is indeed, Jen, a beautiful place to visit all year round. We always love going up there. And my research focuses on addiction, but also media, stigma, sexual reproductive health, and privacy and technology. For conflicts of interest, I do not have any that are relevant to this conversation today. And let's talk a little bit about learning objectives. So I'm going to talk about this new model that's called the Swiss cheese model. It is one that has been used in other public health and engineering contexts, but what we're hoping to do is bring it to the opioid space and help people see how it can be a useful way to both develop interventions and then evaluate the effectiveness of those interventions. We want to recognize that the Swiss cheese model can help with understanding of complex public health challenges. And if we think about the opioid crisis, that of course is a really complex public health challenge. We're going to talk then about the four key domains for comprehensive opioid policy, so prevention, harm reduction, treatment, and recovery, and explain how they all interconnect through this different model. And then we're going to talk through how some of these policy gaps or holes within each of the domain can compromise the effectiveness of our opioid response efforts. So when we think about the opioid crisis, one of the things that we want to think about is just overall the persistence of this crisis. So it has been a long-standing crisis. It's been around since the early 2000s. The first lawsuits were actually in 2000 in West Virginia versus Purdue Pharma. So this is not something that just kind of came out of nowhere. We're 25 years into this. But when we think about it, it's really been something that has morphed quite a bit. And so we want to make sure that when we think about anything related to our crisis and our crisis response, that we're not fighting the last fight. So, like I said, the first lawsuit was in 2001 in West Virginia, and that was related to deceptive advertising. And we can see since then, in just for example, Wisconsin, but nationally, this trend is also happening, that there's been a really steep increase in overdose deaths and related morbidity associated with it. In 2017, the federal government declared the public health emergency. And, since then, of course, we've seen some variation in the use patterns. So, for example, around that 2017 time period was when fentanyl and fentanyl analogs were starting to come onto the scene. And fentanyl is an opioid, but it's also a lot stronger than other opioids that were being used at the time, which can increase the risk for morbidity and mortality. And then what we can see here, which is really encouraging, is that we did see a drop off in overdose deaths. So again, just focusing here on Wisconsin, there's a 35% drop in overdose deaths between 2023 and 2024. We see this trend nationally as well. That data came out here in May for the national data, and it is very encouraging. But it also means that we have a ton of work to do. Because if you think about it, our goal as the Opioid Policy Institute, but I think the goal of many of the folks on this call is to get to zero overdose deaths. And we're still a very long way away from that, both nationally and in each of the states represented on this call. So again, want to encourage and support the folks that are seeing this change or bending of the curve that we saw in the last year, but recognizing that we have a lot more work to do. So when we think about the opioid crisis, I also want to have us think about it as a syndemic. So that means just like a synergistic pandemics, and those are around opioid overdoses, opioid misuse, and hepatitis and HIV. So what we're seeing here with this different framework is that none of these things are disconnected. They are all overlapping in some sort of way. So we don't have opioid overdoses if we don't have opioid misuse or use, right? The HIV and hepatitis outbreaks that we see are usually due to that injection drug use. There are other ways that HIV and hepatitis can spread, but when we see it in communities that we aren't seeing it normally, like in Indiana, like in West Virginia, it's oftentimes due to that injection drug use risk. And then, of course, opioid overdoses are associated with opioids. And so when we think about how we can respond to this and the different layers of response to it, or the different factors that are influencing this syndemic. There are individual layers, right? So those are those issues around individual risk factors. So whether that might be any sort of genetic risk factors or just, taking these substances in isolation, that can increase your risk of an opioid overdose. Injection drug use, if you're not using sterile supplies, that can increase your risk of HIV and hepatitis, or you're sharing stuff, right? So those are some individual risk factors. But we also have community risk factors. So community risk factors can be things like how accessible are medications for opioid use disorder in our community? How accessible are HIV and hepatitis treatment and prevention approaches? How successful are our approaches to reduce opioid misuse in our community? And we can see that there are, remain some really big gaps in that, even though, again, it's been 25 years that we've been dealing with this crisis. And then there are those structural factors too. So let's say that there are, medications for opioid use disorder. What barriers are there to getting it? Are there transportation barriers? Are there barriers for providers to prescribing that medication? Are there barriers to individuals to filling that prescription? So we know, for example, there's been some research that's very cool that are secret shopper studies that try to understand how easy is it to get a prescription for a medication for opioid use disorder, like buprenorphine, right? So we get the doctor to prescribe it, and then we call all of these pharmacies and say, hey, do you even have this in stock? And what we're seeing still is that a lot of places, especially in rural communities, do not stock these medications. So that's a structural barrier that even, with all of these other risk factors, it's still hard to get the medication filled. And we know that there's structural issues across health. So we're again focusing on this opioid syndemic sort of model, which is the idea that all of these things are synergistic. They're all working in a way, all working with each other in a very negative sort of way. So when we think about how complex it is, then of course we need complex policy solutions. So of course the crisis is again long-standing, but even just looking at that 25 years, that kind of negates the fact that in the 20, 30 years before that, we had a lot of move away towards some of the public health interventions that would have been beneficial if those were existing in place. So a lot of what we're still doing in our response is standing up a network of community responses to these things, whether it is trained providers, whether it is syringe service programs, whether it is harm reduction community groups that, for those 20, 30 years before the crisis really started to hit, if those things were in place, we wouldn't have had as bad of a crisis in the first place. So we're still playing catch up. And that is because the crisis is very complex and it's always changing. So why does the Swiss cheese model help? Well, it helps because it recognizes that complexity. But where does it come from? So it comes from the 1990s. The idea of it being like Swiss cheese itself, instead of just like responses that had gaps in it, was in 2000. But what's really nice about it, I like it because it helps us visualize risks across these various domains. And the idea here is that there can be failures that are active. So these are unsafe acts committed by the person in direct contact with the system. So for example, injection drug use, whether you're like sharing syringe supplies. So that's an active failure. And there are things that you would do to try to promote that specific active failure. For example, making safe syringe supplies available, readily available, reducing the legal burden on individuals that are carrying those supplies so that they don't have to like ditch them, et cetera, et cetera. And then there's latent failures that are dormant in the system, but become combined with active failures to create the accident. So, excuse me, the example here is that because we had so under-resourced like addiction medicine for those decades leading up to this crisis, and we hadn't done all of those things, for example, in medical school to train addiction medicine providers. And even today, we're doing better, but we're still not where we are with other disciplines when we look at addiction medicine, right? And so that's a 25-year gap that we have to make up. But really, it's like a 50-year gap if we think about these training gaps. And you can't just train healthcare providers overnight, right? We know that. So that's this latent system-wide failure that when these issues sort of cropped up, we started to see like, oh, shoot, we don't have anywhere near the number of providers that we need to address this issue. And when we're talking about healthcare providers, it doesn't just has to be an addiction medicine, like a psychiatrist, right? It can also be social workers that are trained in this, counselors, peer recovery support coaches, all of those different sort of training in health and allied health professional careers that have really come on board in a big way in the last few years. They're making up for a ton of gaps, right? And it's just hard to get them into that system fast enough. And so that is what we would think of as a latent failure that we really only see when like, oh my gosh, this thing happened. It looked like there were these system-wide things that we just didn't have the framework in place beforehand. Now, they could have been remedied beforehand with proactive risk management. So it's pretty easy to see that not teaching addiction medicine in medical school in the 90s isn't super great. Because, like, when we think about addiction, yes, we've had this opioid crisis over the past 25 years, but alcohol use disorder has always been a really big problem in our country. Nicotine use disorder, again, always been a really big challenge in our country. And so, it's not like this sort of thing came overnight and all of a sudden we got to figure out, like, oh no, what can we do? We can do some proactive risk management. And why the Swiss cheese model helps with that is it really helps us think through, what are these different domains? And we're going to talk about that here in a second. And how do we kind of layer those domains to prevent these issues going forward? So the core concept with the Swiss cheese model is that we have these slices of cheese, and the slices of cheese are the policy areas or interventions. Again, there are different ways that you can apply this model. When we're applying it to opioid addiction and opioid-related stuff, we're going to talk about these policy areas, and then within them, there are these specific interventions that are additional slices. The holes in the cheese are those active or latent conditions that contribute to gaps in that intervention. And then the trajectory of failure is just when those holes align across multiple layers, we can expect to see some harm. So when you think about the Swiss cheese in this case, we have the slice of cheese, that is the policy. Those holes are those active failures or latent failures that can contribute to people like slipping through the gaps, so to speak, in that layer of the intervention. And that trajectory of the failure is when we have those multiple layers and that individual, again, like kind of slides through all of those gaps. And then we see these harms in our community. Okay, so let's talk about this in relation to something different from opioids. And then we're going to dive into this as an opioid framework. So the Swiss cheese model, when we think about it with COVID, we also have things like prevention, harm reduction, treatment, and recovery. When we're thinking about COVID-19, what a failure would be is a morbidity or mortality event. So those are in many cases preventable, right? And success is just preventing those things. So when we think about prevention in COVID-19, what would be those things? It'd be stuff like vaccines or contact tracing. So those are things that we know that can like prevent the spread of this of the virus when it was, well, just any virus really, right? If we have vaccines. So we have those prevention interventions. Now, what's important here when we think about the Swiss cheese model is we do have gaps in that, right? Like contact tracing isn't perfect. Vaccines aren't perfect. They don't work in all situations for all people. Some people can't take vaccines for any number of reasons, right? And so that's why when we think about, applying a Swiss cheese model to a public health thing like COVID-19, that's why this next layer is going to be important. So what are these harm reduction approaches? We can do masks and physical distancing. Again, any one of those things in and of themselves would not be sufficient. But once you start to see the layers, we start to reduce some of these gaps in between the system and reduce that failure going forward. Treatment would be those antiviral medications, and then recovery are things like long COVID supports. So what I really like about this model, and this was proposed for COVID-19, there was some good writing on it at the time, and that's how I became aware of it. When I saw it, I was like, oh, this is just, they didn't use the framing of prevention, harm reduction, treatment, and recovery, but like this really nicely slots onto what I think about as what would be good policies for addiction and opioid policy in particular. But what's nice about this is, again, it recognizes that none of these interventions or none of these layers are in themselves sufficient. We want to have layered approaches. And again, those layered approaches, even for something like fairly straightforward like a virus, is going to be what's needed to have our best outcomes. Because there's no one aspect that would completely eliminate morbidity and mortality. And so the best way to do that is to work systematically to reduce those issues. And then it's important to note that, like, just because there are holes in any one intervention, that doesn't necessarily mean that there's going to be a bad outcome, right? It only really happens when those holes align across all of those things. So, like, an individual that is unvaccinated, doesn't wear a mask or social distance, doesn't use the antiviral medications that are available, the likelihood that they have a failure or a morbidity and mortality event is obviously a lot higher because they're in all of those gaps, right? And then what's nice again, long term, is that you can look at this when we have our Swiss cheese model for our public health intervention. You can go back and look at it and see if there was a failure. Okay, at what point did we have that failure? And what policy things can we do to try to change or prevent those failures in the future? So let's apply this to opioids. So with the opioid crisis, a failure is just that opioid-related morbidity and mortality event, and then success is preventing those things. And again, we have our prevention, harm reduction, treatment, and recovery. And what I do want to recognize here with opioids in particular is that these boundaries aren't always super clear as we're making them here. From a policy perspective, what's most important is not like what things are in what bucket, but just that you do define those buckets. So some of the things that I'm going to talk about here, you might think of as prevention instead of harm reduction, or you might think of as harm reduction instead of treatment. And that's totally cool. Yeah, I can like with many of these things, I can see it a few different ways, and I wouldn't argue with you on that. The bigger idea is that like having these domains pre-established so that you can go back and evaluate is super important. So you can only really evaluate them when you create that definition from the first place. And that's just like the scientist in me talking, right? We want to have these clear definitions. And then we also want to recognize that your goal and definition of each slice, of course, is going to depend on how it fits in your local community and any states and local policies that could be barriers to these approaches. So, obviously it is, again, very complex. So let's talk a little bit about prevention. So the idea with prevention is to stop opioid misuse and opioid use disorder before it starts. So there are a few different ways that we can do that. We can do things like school and community-based prevention efforts. oftentimes the ones that are successful aren't just drug focused. Most of them are just youth prevention efforts that work towards other youth related goals, like healthy activity or like avoidance of gangs or bullying or any of those negative youth behaviors that we're trying to prevent. Again, like the most successful youth prevention ones, like target basically have impacts on all of those things, and drugs. Because one of the trickiest things with substance use is that like when we're looking at that demographic of use in prevention, like most youth aren't using opioids in a way that would be problematic. So stopping opioid misuse, that's already like a pretty small subset. And then we're not seeing a ton of opioid overdose deaths at that. So like stopping that would be even like harder, right? Just because like percent wise, there's so few people in your community that are at risk of that. So what we really want to focus on with school and community based efforts are things that like overall broaden and improve youth well-being. And we can see those things have those other downstream effects like on drug use. Prescription data monitoring programs can help flag doctor shopping or unsafe prescribing practices. PDMPs are controversial. I don't have a ton of time to go into that today, but they are oftentimes considered part of the prevention bucket. And sorry, I should have said this before we jumped in. A lot of this I want to help people think of when we think about the opioid settlement spending. And so, why that's relevant is that with approved uses of spending in Exhibit E, there are these buckets of prevention, harm reduction, treatment, and recovery. So, for example, PDMPs and youth prevention are two interventions that are approved uses of opioid settlement spending in the prevention domain. And so, again, PDMPs can have some impact, but like when we think about prevention as a whole, we want to make sure that we're doing all of these different elements, right? To really, really, really really effectively do prevention. Education efforts for providers. So this can be related to prescribing and screening, brief intervention, and referral to treatment. We know that that is a prevention approach. So for example, if my PCP knows how to screen for substance use disorders, opioid use disorder in particular, they know how to do a brief intervention and a referral to treatment or provide treatment, that education can prevent the further development of my opioid use disorder, right? Because when we think about opioid use disorders, we want to think about them on that spectrum of mild, moderate, and severe. The earlier that we intervene, so prevention, right? The earlier that we intervene and we prevent it developing to moderate or severe, the better our outcomes. So making sure we have education for providers to help prevent those things developing and getting worse, totally great. And then safe prescribing. So this is following evidence-based guidelines that are developed and using non-opioid pain management approaches when appropriate. Stigma reduction is also really important. Stigma reduction is another one of those ones like really that could be a slice in any of these domains, whether it's prevention, harm reduction, treatment, or recovery. But let's lump it into prevention. And the idea here is that, as Amanda said at the beginning of the call, we want to make sure that we create a space that is safe for individuals to receive treatment and when they're in long-term recovery. And so we can only do that by talking about people with respect. If we think about our own interactions with healthcare providers, the ones that we really gravitate towards or appreciate are the ones that are treating us with respect, right? Those are the ones that I'm going to sign up to see again. Those are the ones that I don't like kind of groan when I have to schedule an appointment with them, right? Because I appreciate talking to my primary care provider. They are very respectful of me and they do a great job of understanding where I'm coming from in my condition. Now, if I was a patient that was treated poorly by a health provider, and I have been treated poorly by health providers, I'm not going to be like, oh, great, I can't wait to see them again. I'd be like, maybe I'm not going to show up to that appointment. Or maybe I'm going to try to schedule a new one. Or as the appointment's coming, you're just like, you know what, screw this. I don't even like this person anyways. I'm not dealing with this, or I'm not going to listen to what they said, etc. So all of those are things that if we can do this stigma reduction, help people be treated with compassion and respect, we can increase some of these other outcomes. But again, prevention, when we think about stigma reduction in that prevention bucket, it is trying to prevent like folks experiencing those negative outcomes related to those health professional interactions or just interacting in our community. Right? We want to make sure that our community also isn't making it hard for folks who use drugs or are in recovery. It's really hard to find jobs, right? And so we want to make sure that we do stigma reduction efforts among employers so that they know, like, hey, if these folks are in recovery and they meet the criteria for your job posting, like you should be hiring them, right? Because the only way that we're going to get improvement in some of these things is if they can get back into, living a happy, independent life, and workforce, or being an employee is a part of that for a lot of people. So some examples of gaps are stuff like inconsistent use of PDMPs or problems with the mandates, gaps in prescriber training on addiction or pain management. So, like I said, when we think about medical schools, are our medical schools or fellowships or residencies, are they really helping people understand those different parts of addiction, those different ways to prevent addiction, like those alternative pain approaches, right? And if we're in a place that isn't getting that information, then it's going to continue to be a challenge for our community because our providers don't know how to prevent some of these things from developing. Insufficient funding for youth, evidence-based youth programs is going to be a big one too that really cuts against our prevention efforts. Limited access to insurance coverage for non-opioid pain treatments, and then just public efforts not reaching those high-risk populations. So if we have, for example, education campaigns or stigma reduction campaigns, are they making an impact in that space that we need them to have an impact in? And are we able to evaluate that? So again, going back to why I like this model is, let's say your prevention slices look a little bit different from your community. That's totally fine. But what you want to be able to do is then lay out those slices, and in a year, 2 years, or whatever, look back and try to see, like, how are we doing with the youth prevention bucket? How are we doing with the PDMP bucket? How are we doing with the education? And are we seeing any issues or gaps across these things that we can continue to address, either with different types of funding streams or different resource allocation or concentration on those different aspects? And then, of course, the consequence of not doing these prevention efforts is more individuals initiate opioids unnecessarily, which is a high risk for developing opioid use disorder. All right, going back to our broader model. Now we are going to get into harm reduction. So, harm reduction is just that recognition that not all people are willing or able to stop using drugs when they initiate drug use. Harm reduction is meeting people where they're at and providing a safe and effective support that reduces negative consequences associated with that drug use. So that's really important. It's the idea that, like, we both recognize that people are going to use drugs, but if they're going to use drugs, we want to make sure that they are using them in a way that is safe, that doesn't cause that morbidity and mortality. Now, taking a step back from, like, harm reduction in this specific example, let's talk about harm reduction more broadly. So something like seat belts or sunscreen are also harm reduction approaches. I don't know, not all of the states that are on this call have mandated helmet laws for motorcycles, but that's another, like, harm reduction thing, right? And so the seatbelts, as an example, seatbelts weren't always something that were available, right? There were public groups that advocated for seatbelts because it was very unsafe to drive without them. And there is a period that they were phased in, and now you have to wear a seatbelt if you're driving your car. The idea for that is that it's safer for you and safer for the environment if you're in a crash, that your body isn't just like rocketed out of the front of your car, right? It also helps keep everyone safe, of course, in the car, but it's a public health harm reduction approach because it kind of does all of those things, right? So what they're recognizing is that, like, people are going to drive cars, and driving cars, especially at certain speeds, is inherently unsafe compared to just walking, or like how we used to get around on, like, horses or stuff, right? So if we're going to recognize that, like, hey, it could be a little bit unsafe, what can we do to kind of reduce some of that risk, because people are going to engage in that behavior? Same with motorcycles. People are going to ride their motorcycles. We want to make sure it's as safe as possible for them and the individuals in our environment. So some states mandate helmet laws. Okay, so shifting back to harm reduction for drug use. So harm reduction, again, recognizing that, people are going to use drugs. So what we need to do is make it safe so that they do not experience the morbidity and mortality, but are able to access treatment services as needed. So some ways that we can do that are things like naloxone. So that could be access and training. So what I want to flag here with naloxone, what's really important with naloxone from a harm reduction perspective, is making sure it's increased in at-risk or high-risk populations. It doesn't do a whole lot of good just to have a bunch of naloxone everywhere if the people who need it most can't access it. And we still see this being an issue, again, like 25 years into this crisis, where the people that are at highest risk of overdose continue to have a hard time getting access to naloxone. So when we're thinking about harm reduction and we're thinking about that naloxone bucket, it's not just making sure naloxone is available, it's making sure it's targeted for those groups that are at highest risk. Syringe service programs are another thing that we know can help with morbidity and mortality and connect people with treatment services. So syringe service programs provide sterile use supplies like the kit or cookers, like the syringe itself, and that reduces that risk of infectious disease. So that's overall like net positive, right? But the other thing syringe service programs do is they help people get access to some of these other support services. Sometimes it's naloxone, sometimes it's the test strips, but sometimes it's also just like treatment. Somebody comes into an SSP and says like, "Hey, I'm actually like, I think today's the day I'm going to quit." Having that SSP there that can like help funnel them into those support services can be a really important public health intervention. And then we have fentanyl test strips or xylazine test strips. There's, and the nitazene test strips. There's all sorts of different test strips because again, the drug crisis is always shifting. So what was a really big fentanyl crisis, like 8, 9 years ago, fentanyl's still in the drug supply, but most people who are using opioids, especially injection drug use, like they understand that there's fentanyl in the drug supply. Like that's not news to them. What is some of these other contaminants like the nitazines, like xylazine, and the impact that those might have on how they use the substances. So we want to make sure that we have these test strips that are available. And then those overdose prevention sites, sometimes called safe consumption sites. So these are places where people can safely use those substances. It's kind of like an SSP, but like plus being able to use the substance there. They are clean and sterile environments. They have naloxone on hand. People don't overdose and die in those situations. So again, that's a really important like harm reduction thing. If we can help people like stay alive, then we can help them get treatment. Overdose prevention sites also, like SSPs, can help people access those other services that they need to be healthy, including treatment services. So when we think about these things and the gaps, some of them are legal or regulatory barriers around naloxone distribution or SSPs. So not everybody allows, syringes could be considered drug paraphernalia. So if a syringe is considered drug paraphernalia, like let's take a step back. Even though we know a sterile syringe would reduce the risk of HIV, right, or Hep C, or any of those things that we know are one very costly to that individual in terms of like their overall health, but incredibly costly from a public health perspective. Syringes are not, so we have syringes available. Now, let's say in my community, a syringe is considered drug paraphernalia. I could hand out all of the syringes that I want, but some of those are just going to be tossed because that person does not want to be caught with a syringe because they know that they could be written up for drug paraphernalia, right? So we want to make sure that there aren't these legal or regulatory barriers that exist that like reduce the impact of these harm reduction approaches. Something like naloxone, and I think every state now has it, but we had to have was these Good Samaritan laws put in place that if you administered naloxone, and it did or didn't work, you wouldn't be held liable for the use of or for like administering the naloxone. So that's a good example of like a legal regulatory thing that helped kind of unlock the ability to use those substances, right? And if we saw some of these issues come up where like naloxone isn't being used, we could reevaluate. Maybe there are different regulatory things that we would need to do. For example, there are some states that are putting into place laws that like block certain purchases of different naloxone products. A lot of those are being pushed by one specific pharmaceutical company, and that's a real big problem because they just want to lock down that market, right? Once they lock down that market, the cost of naloxone goes up or is already too high, and now we can't distribute as much naloxone as we need to in our community for these high-risk people. So really looking at these legal and regulatory barriers can be really important step of this harm reduction piece. Again, stigma is, like we said, part of the prevention stuff, but stigma can also prevent utilization of some of these services or development of these services. So if you are a county commissioner or you're someone trying to decide, maybe you're on a board that's trying to decide how to use opioid settlement money, your belief about some of these harm reduction approaches can really drive you away from them in some places. And a lot of those beliefs are either outdated or not aligned with the scientific research on like what are these things able to do. So we know SSPs, for example, really, really in a huge way drive down costs associated with those public health morbidity or mortality events. Same with something like naloxone or test strips or overdose prevention sites. Now, again, what I'm not saying is that every community needs to have an overdose prevention site by the end of this call, but we should be at least thinking about, is this the type of thing that would fit my community and address the specific thing that we're seeing? And what I would guess is that more communities than not could actually see the benefit of that. But again, there's a lot of barriers to getting there. And then, of course, funding is a huge issue. Funding for these specific things is a really big issue. So, for example, a lot of federal grants don't allow you to use, or specific grants don't allow you to use money to buy, for example, sterile syringes. They might allow you to buy naloxone. So then, how does that group that does harm reduction, like, how are they able to provide all of the services that are necessary? Because when we think about this again as that Swiss cheese model, if we slot out that SSP slice of cheese, all of a sudden the ability to fall through these cracks gets a ton easier for individuals. And that's why we again see a lot of people falling between all of these gaps because we don't have all of these different slices in place to like reduce these issues. And then, of course, consequences for harm reduction stuff are higher rates of overdose deaths, transmission of infectious disease, HIV, Hep C, and missed opportunities to engage people in care. All right, now let's jump back into treatment. So when we're thinking about treatment, what we want to do is make sure we're providing access to evidence-based approaches for individuals with an opioid use disorder. So when we think about treatment, what we want to think about is the different American Society of Addiction Medicine levels of care. So what I mean by that is American Society of Addiction Medicine, or ASAM, has a list of all of the different types of treatment that are available for addiction. When we think about our community, we want to think about, are we providing each of these different aspects? If not, is the next county over providing it? Maybe we can do some sort of synergistic stuff. Maybe we can help with transportation. It's like, I don't think that every place has to have inpatient services, but you need to, if you're in that community, understand like, where are these services actually accessible? And if they are not, then maybe it is my community that needs to stand them up. So the ASAM levels of care are outpatient, intensive outpatient, residential, and inpatient. A lot of time when we think about treatment, people focus on that residential and inpatient, which is the most extreme approach because it does include like that, that 90-day sort of thing. But a lot of folks have that 90-day model in their head for like, that's how you treat addiction. That is not necessarily the case. And a lot of people have great outcomes with outpatient or intensive outpatient. So outpatient could be done by your primary care provider. Intensive outpatient could also be done by a community-based primary care provider, potentially someone with addiction medicine training or support. And what those things can do is, of course, increase access to care at a much lower cost than like standing up residential or inpatient facilities, right? So you don't have to do that residential or inpatient. And I talk to folks about this all the time when they say like, hey, we can't find treatment in our community. I say, hey, like, does the PCP that services your community provide access to medication? Do they prescribe the buprenorphine, which is a medication for opioid use disorder? Like, I don't think they do. Well, that's a great place to start because if you can get that PCP to prescribe this medication, or you can get a few different of your health providers to prescribe that medication, you don't have to wait for this huge building to be built and this residential place that you need to staff and stop all of those things. There are these things that we can do in the interim that can really increase access to care. One of the ways that we do that, and I mentioned being affiliated with Michigan State, is something called MyCares, which is the Michigan Collaborative Addiction Resource and Education System. MyCares is a group of online training modules that can help folks understand and increase access to treatment by providing a spectrum of training for addiction medicine and other health professionals. So we have residency training, there's medical school curriculum, there's social sciences curriculum for social workers, for example, and we're always building out new modules. So if you're in a community that like, again, needs access to these services, or you're a provider, or providers that are interested in learning more about it, we have this training that's available through MyCares. Again, just I'm affiliated with it. That can help folks access some of these educational modules to learn how to treat substance use disorders. All right, so we have those medications for opioid use disorder. We also have our behavioral approaches. So that can be things like cognitive behavioral therapy or contingency management approaches. So contingency management is a treatment approach where people are provided rewards for not engaging in the behaviors that are problematic. So for example, they might receive a reward for coming in and having no drugs in their system. Or they might receive a reward for coming in and not having opioids in their system exclusively, or just attending appointments. There are different ways that you can structure those behavioral rewards. And the goal there is that it helps people like engage in the healthy and preferred behavior. And when we think about it, it makes a lot of sense intuitively. If we are rewarded for things, we just generally tend to do them more. That's not like an earth-shattering thing. The thing that was holding back contingency management was that for decades, the amount that was able to be given as rewards was just like not enough to be effective. So recently in December of this year or last year, sorry, they upped the amount that is available for contingency management rewards. And it's more in line with what the research suggests would actually like drive these changes in behavior. So those are some behavioral approaches. Again, like this talk doesn't have enough time to go comprehensively into each of these things, but contingency management is a great intervention. It's a behavioral intervention, really, really not widely used. And again, there were those policy challenges, but we want to make sure people are supported on those things. Mutual support groups or stuff like AA or NA, again, those can be really important for folks. So making sure that those are available in our communities. And then integrated services. So for things like OB, we want to make sure OB is also integrated with addiction medicine so that if a patient comes in and they're pregnant and they're using drugs, they're able to access those addiction medicine or support services while also receiving their OB support, for example. Some example of gaps in this cheese is shortage of MOUD providers, reimbursement issues around that. We all know that that's a really big issue. Insurance barriers like prior authorization or just cost for appointments or treatment. A lack of treatment availability in rural and underserved areas and correction facilities. And then poor integration with mental health services broadly. So again, we want to make sure that all of these things are synced up when we're thinking about treatment. The consequences of having these gaps is that individuals are unable to access or stay in life-saving treatment, and they cycle through these crisis systems, right? And we know that that's the biggest challenge is one, getting people to the help that they need, but two, like breaking the cycle of addiction. The only way we can break that cycle of addiction is we access these evidence-based treatment programs. And I can't stress enough that when we're talking about treatment, we're talking about these evidence-based approaches like these medications like buprenorphine or methadone or naltrexone for opioid use disorder. The other thing that I want to stress here, and then I talk about in some of my other talks when we talk about these different interventions and treatments, is that when we think about these different layers should be available in our community and or in our treatment system, but they're not necessarily required for all individuals. So a lot of places still like make you attend mutual support groups, AA or NA, if you're going to be prescribed the medication. That's a problem because the treatment itself is the medication, and we don't want to increase barriers to receiving life-saving medication. So there's been a lot of work by the American Society of Addiction Medicine and other groups in the addiction space to help providers understand and communities understand that like the thing that you need is the medication. All of these other things are like really important. These behavioral approaches, mutual support, integrated services, like all of those things can help reduce those negative outcomes, right, going forward. But none of them are required before medication for opioid use disorder. So you can see, I very smartly put medication for opioid use disorder as the foundational piece, right? That is the main thing that you got to have. These other things are also important in our community, but we want to make sure that they are not themselves barriers to receiving that medication for opioid use disorder. And that is too commonly still the case. All right, lastly here, let's talk about recovery. So when we think about recovery, what we're talking about is supporting individuals in maintaining long-term remission or improving their quality of life. What's really important with recovery is that recovery is defined by the individual in their own treatment journey. We might have a perception of what recovery should look like, right? Maybe we think it is abstinence. Maybe for us, as someone that's in recovery, abstinence is really important. That doesn't mean that abstinence is important for all people or in all situations. And so we have to make space in recovery for people that are on their own recovery journeys, and that might look really differently for different people. At the end of the day, though, we still want to make sure that we have these resources available for folks, and that there aren't barriers to them for people that are in those different types of recovery journeys. So, for example, stuff like recovery housing. There is some recovery housing still to this day that does not allow you to have those medications for opioid use disorder while you are in the recovery housing. It's a huge problem. Just like we were just saying before, where like the medication is the treatment when we think about when we think about those like mutual support groups like AANA, right? If we if we have it as a requirement or we actually block you from taking that medication to be in this housing, that does not lead to better outcomes. And we know that can actually be super dangerous. So when we're talking about how recovery housing, we want to make sure that it's implemented in a way that like doesn't cause further harm. Employment assistance can be really important. I like to talk about there's a clinic in North Carolina called Horizons. It is an inspiration. Again, I know not all communities are resourced in the same way and able to do this, but one of the things that they do is they have an industrial kitchen as part of their treatment facility. So part of what they do is they help provide job training and support. So both in that industrial kitchen, people learn how to, they were running it as like a little mini store where they were selling like muffins and stuff like that to some local community not bakeries because they could bake their own muffins. Maybe it was restaurants and stuff. So they can sell that, but they also like get job training and support. So they help them with their resumes, they help them with interview prep, they help them with clothes for that, they help them with transportation to the interview, like make sure they have a bus pass, all that sort of stuff. That employee assistance is huge. And I know that like this is kind of a tricky part of recovery is that like return to be a contributing member of the economy. But that is often how recovery is defined because that quality of life is derived from the ability to like earn an income. Now, of course, earning a living wage and income isn't always accessible, especially nowadays. So employee assistance is just like one small step towards that. We need to do other things, of course, to make sure folks can like live with just one job, et cetera, and have those supports that are available to them. But employee assistance, really, really important part of recovery support. Peer recovery services or peer support services are things like recovery coaches. So that can be both an employment avenue for some folks that are in recovery, but it's also just important to have those peers that can help you navigate this part because, well, navigate any part of this journey. But when we think about recovery in particular, if we think about addiction kind of as like, so there's that acute drug use that's happening in that short time frame, right? And then we have that active addiction. The idea is to kind of cut that off as quick as possible, right? So we don't have a long-term active addiction because the longer any chronic disease goes on, the worse the outcome. So we intervene early. So let's say the drug use is happening in your 20s, the addiction's happening in your mid 20s, the treatment's happening in your 30s. Now that next 30 to 80, 90, that other 40 or 50 years is in that recovery bucket. So we really want to make sure that folks have the support that they need for that rest of their life, right? And peer recovery support can be one of those things that can help them navigate those different parts of their life and different steps on that journey. And then, of course, something like transportation. Again, transportation is something that you can work into treatment or harm reduction. But I like it here just because those community supports are really important and making sure people have access to the services that they need or ability to like be functioning members of society, however they define that, is really important. We can't like negate the fact that or can't kind of ignore the fact that some folks during their active addiction maybe had lost their ability to have transportation, whether it's operating while under the influence, not having access to a vehicle anymore because those are expensive and hard to maintain with insurance, et cetera. So like transportation is just a really big part of this. Examples of gaps in this is scarcity of affordable housing and or just recovery housing in general. Employing or housing discrimination, so that's a huge issue. Discrimination against someone for having an opioid use disorder or an addiction is illegal under the eyes of the law because it is a protected health condition and it is considered a disability. However, we know that like the harms that come from discrimination come way quicker than the remediation of that legal system. So, for example, I've worked with folks who, they did a media interview and they talked about their drug use or addiction, and they came home and their stuff was on the curb. Their landlord had kicked them out, and that's illegal. And that's really, really like, I can say stronger words, but that's really a huge problem. It's really concerning. It is really like just not it's not helping anyone. It is associated with stigma and discrimination, and that person could fight it, right? They could get a lawyer and they could demand that, but at the end of the day, their stuff's on the curb, right? And so what we want to do is make sure that we're creating environments where that discrimination doesn't happen in the first place, because we have those stigma reduction efforts and we help people understand these things and we help people understand the value of providing housing for folks that are in long-term recovery. Making sure that there is support for peer recovery services. And that can also include making sure that those are well-paid jobs, but also like have the benefits like insurance, et cetera. Oftentimes, how peer recovery support services are used nowadays is like they're still given like the hardest cases. They have the least mentorship and support, and they have the least resources compared to other people on the team. And so we want to make sure that if we're going to do peer recovery support services, that we're really stood up in a way to be successful. And also recognizing that, like, if we're talking about peer recovery services, we're also talking about people that have also experienced some of this trauma in the past. So, like, what are we doing to help support that individual long term to make sure that they are getting what they need? Peer recovery services, it's a really hard job. It's a really rewarding job, but we got to do more to make this a sustainable job for folks as well. There's also persistent social stigma, like we talked about already, and limited support for families. So, any of these things, whether it's recovery housing or employment assistance or those peer recovery support services or transportation, we really want to make sure that any of those things also hit on folks that have young children or include folks that maybe need to do additional appointments, whether it's child protective services, whether it's court ordered stuff, but that they're able to access those things. The consequence of not having these recovery supports is those higher rates of return to use, difficulty reintegrating into society, and continued long term instability. Okay, so taken together, I think it's clear, hopefully, to see that these are not isolated silos, but they're all interconnected layers and sublayers. So you can probably see why I didn't have all 16 layers on one slide, and that I instead try to focus on these four overarching layers. Again, these four layers are the ones that I have identified through my research and other, conversations, all of the things that I do to help like develop these models. So I do think that these layers are in themselves like the right layers. But again, like how you implement that in your community, like what does recovery support look like in your community is only something that you can answer. We can, of course, help with that, and we're happy to have those conversations. And you can find us through that opioidpolicyinstitute.org. We can have these conversations about like what this looks like or how to do this, and happy to do so. But generally, like the idea that these are your four buckets or your four slices, you don't want to not have any of these slices, and you don't want to not invest resources, time, energy into these slices. Too often, when we look at opioid settlement spending, for example, what we see is a not synchronized spending across the state and county or municipalities, but also like focused on specific parts. So maybe one place is super focused on naloxone. Again, like naloxone is great. I really think that it should be more available for those high risk individuals. But if you're not doing stuff to also increase access to treatment, providing recovery supports or prevention, then you can see how like we're just not going to be able to pull ourselves out of this crisis with just naloxone or with just medication for opioid use disorder, or even just the two of those things, right? We really need to think about this as a very high level, layered sort of approach. The idea here, too, is that, like, again, these things are interconnected. Weaknesses in one domain can strain the others. So if we have bigger holes in one domain, so like let's say, for example, in prevention, if the only thing that we're doing is youth prevention, and again, youth prevention is like kind of shaky in some ways, but if that's like the only thing that we're doing, then like we're going to have a lot bigger holes in the prevention bucket, which means we're going to have a lot more people. Well, not, it's not like billions of people, but we're going to have more people that are developing that active addiction because we're not preventing it, right? Which means we're going to put more strain on harm reduction, treatment, and recovery. So you can see how that like kind of has this cascade effect. And the holes can move, which is kind of, as a policy person, it's kind of fun, but also like really challenging to keep up with. Because of those landscape aspects. So things like changes in the drug supply. So when we think about the opioid crisis, we have that initial wave that we talked about on that Wisconsin example that was primarily prescription opioid medication. That shifted to injection drug use, which then shifted to fentanyl. So that's the third wave. And this fourth wave that we're experiencing now is stimulants plus opioids. So over the course of 25 years, our crisis has changed quite a bit, which means that our policy approaches are changing quite a bit, or at least should be in response to that crisis, right? Like, does it make sense right now with the opioid crisis to pour a bunch of money into fentanyl test strips? I'm not sure. Because, again, like most people understand that fentanyl is in the drug supply. So maybe it's more just doing awareness around fentanyl being in the drug supply, right? And it's doing other things to test the substances to make sure that people know what the other things are that are contaminating them that can cause those issues. But we want to make sure that we're engaged with the crisis as it is in front of us, which also means that we have to have really good data and surveillance systems to understand like where this crisis is and where it's going. Keep in mind too that strength in one of these layers supports those others. So if we have early screening and interventions, that can increase those positive outcomes downstream and also reduce costs for those downstream parts. The problem with the opioid crisis as it stands is we're still kind of pretty much, for the most part, in a like the full house is on fire. Again, like we were able to see some success in the last year with bending that curve and of opioid overdose deaths, but it's still not zero. And it's like not even close to zero, which is what we need it to be, which is what it has been in the past. So we can get there, but only by making sure that we have these things that are reinforcing and supporting each other. And then, of course, when those holes align and we have those bad or those negative outcomes, we want to make sure that we can do things to look back and see like how did this morbidity or mortality event occur? So only then can we kind of like trace it all the way through and see like, hey, we're underinvesting in this, or actually like things have changed, or this policy continues to be an issue maybe for syringe service programs. And so, like, we keep seeing these HIV and Hep C outbreaks in our community. Well, we're going to have to do something to address that policy. There are examples, for example, in West Virginia, again, where they had syringe service programs, and then there was this big public, well, not public, political backlash against them. They got rid of them in many cases, and then they saw this big Hep C and HIV outbreak. So not super surprising as a public health person that like that's what you would expect because people didn't just stop like injecting drug use in a way that would be risky. But like you could see that like all of a sudden this huge hole in the cheese was created, and now all of a sudden downstream, when that treatment and recovery, we have a huge burden on those things that we still do not have supports for. And I also want to like kind of get us away from the idea of like slipping through the cracks, because when we think about this model, we can see where those cracks are. So what we want to do is make sure that like we're doing everything we can to reduce the cracks, and that we're not like creating any new cracks. And that if we identify a huge crack, like for example, not having syringe service programs, that we do everything that we can from a policy and resource perspective to close that, because it's really like you can't look at harm reduction and be like, wow, like I guess they just keep slipping through the cracks and that's why we have issues. No, these are policy issues that are driving to these negative outcomes. So the opioid settlements are one way to address this, but another way is just to understand and broaden our understanding of these issues. Okay, I'm going to give an example here with Wisconsin and how they're spending opioid settlement money. Again, this could be done in all of the different states, and we're working on this across all of the different states. But Wisconsin's a really clear example. So they're spending money on school-based programs, after-school and community-based programs. So they're putting some money in prevention, and this is just the state money. And this is just like the 30% that went to the state. The other 70% is going to those counties and municipalities. So they're doing some prevention stuff. Cool. They're doing some harm reduction stuff like naloxone and fentanyl test strip and peer support services. Cool. They're doing treatment stuff, which are primarily capital projects. So they're building some buildings or improving buildings, doing stuff at the Department of Corrections. They're doing some mobile stuff. They're trying to close some Medicaid gaps. But there wasn't a ton, at least on the website, that was clear of what they were doing related to recovery stuff. Now, that could be peer support. How they mentioned peer support was in the harm reduction space as opposed to recovery. But again, like you kind of see maybe. But when you look at this, the Swiss cheese model, right? So if we have a great prevention, harm reduction, and treatment, maybe we're doing all the things that we can there. If we have a ton of holes in our recovery supports, all of a sudden that burden falls back on the treatment, harm reduction, prevention space, because these individuals, it's a lot harder to stay in our recovery journey if we don't have these recovery supports that are available. Which again, we're trying to do this for every state. But the idea here is that we want to make sure that like, we're thinking about spending across all of the 4 different domains. And we also want to recognize that like, this is 25 years, right? built on top of 50 years of inadequate spending, and I don't expect all of it to happen overnight. And I also don't expect all of these things to look the same in every community, right? Again, your community is going to need your own boutique, bespoke solution to this. But I guarantee you, a solution is going to include prevention, harm reduction, treatment, and recovery. Because anything that doesn't at least include those four levels is going to be completely insufficient. So we have a lot of ground to make up. We can do more targeted things to increase our the policy and interventions that we have. That we want to make sure that we're addressing these things. Another step in this opioid settlement spot is to make sure that we have these needs assessments done before spending. So whether you are the state or you're a municipality, have you identified how much money is already in prevention and what efforts are being done there? And are they evidence-based? Same with harm reduction. What are we already doing in harm reduction? And what do we need to do going forward? And what is blocking our ability to do that going forward? What does our community say they need? And how can we respond to that with this opioid settlement money? Same with treatment and recovery. So that needs assessment is kind of that core component. And I know a lot of people are still working on them, or I know they're very hard to do, and they're very hard because they're comprehensive. But this opioid settlement Swiss cheese model can like kind of help you get towards that, because you can easily see, hey, here are the slices. Now let's talk about these slices underneath it. What are we doing? What are we not doing? What can we do going forward to like address that? So the model is not perfect. I like it, but I don't expect everyone to like run out and like use it immediately. There are some pros and cons. The pros are that it's, I think, very easy to visualize. It's clear to see what these slices are. It's clear to see that there can be gaps in those slices. And again, it gets us away from this like silver bullet sort of thinking about the opioid crisis. Like, oh, we just need to put more money into X. Now we need to put money across this continuum. And we need to make sure that we're pulling all of the levers that we can to make sure that money is dumped into each of these four buckets in ways that are evidence-based. I guarantee you, if you went and looked at some of the spending that you're already doing in your community, some of it's going to be non-evidence based. And so as much as it's hard to like figure out how to shake some of this money loose or how to spend the opioid settlement money, one of the quickest and most effective things we can do is stop spending on things that don't work. And so only with an evaluation model can we help understand that. And that's where I think the Swiss cheese model can kind of help with that, because it does, again, broaden our aperture. And it doesn't introduce, even though it's easy to visualize, it introduces quite a bit of complexity. Um, this is almost an hour into the call. We've gone over a lot of different aspects of the policy response to the opioid crisis. But I hope when you leave it, like you're able to like keep in your mind, well, there's four main slices. So what are we doing for these four main slices? And then you figure it out from there. So, while it is a complex model, it's not so complex that it's completely overwhelming and paralyzing for folks, I hope. There are some cons though, in that like it could oversimplify things a little bit, right? Especially since systems are complex and modern, they're very dynamic. Like this model itself is static because it is just like layers of Swiss cheese that are sitting there. You can be updating it, of course, and making sure that it is like yearly or whatever, like continuing to reflect the drug crisis as we see it in our community. But that does take time and effort, and the drug crisis is not a static thing. It is quite dynamic. Um, it also might miss, because of that, it also might miss some of those situational changes that are happening, because in reality, the holes are continually opening and shutting and changing locations. And that's just, that's the reality of it, is that it doesn't really do a good job of understanding that. So, for example, a few years ago, if we had a spike in overdose deaths here, I'm in Grand Rapids, Michigan, if we had a spike of overdose deaths, it might be because fentanyl was new to the drug supply. And so, if we think about that harm reduction, treatment, prevention, recovery sort of thing, like since fentanyl was pretty new, like we didn't quite know what that hole was, but all of a sudden, fentanyl like blew a huge hole into that model, right? So again, making sure that we're always trying to keep aware of these changing trends and have good data and surveillance systems to do that. And then lastly, the whole origins aren't really explained in the model. All it says is that there are these gaps, but like understanding what those gaps are is important, and like where they came from. So, that why question of like why this gap is there in this slice of cheese is super important for how to address it. And all this model shows is that like there's a gap. And again, I recognize that that is a very simplistic understanding of it because there could be legal issues, there could be just community-based issues. Maybe it's a community that tried some of these things and it just like didn't work for that community. Totally fair. It doesn't show why why that gap is there. It just shows that it's there. So we want to make sure that we're evaluating those things. So in summary, the Swiss cheese model can be a valuable framework for understanding systems and their vulnerabilities. We do think that the four interconnected aspects to comprehensive overdose prevention, morbidity and mortality prevention are prevention, harm reduction, treatment, and recovery. We want to make sure we address these holes in each layer, and that's crucial to building a more robust and effective response. And that no single layer is foolproof. That strength only comes from multiple reinforcing layers. So again, we just want to make sure that you are thinking through, and maybe this is a model that works for you, especially if you're a decision maker. Happy to talk about it more and how you can implement it. But consider where those holes are in your community response and how they can be remediated, hopefully again with opioid settlement spending. So thank you. Really appreciate everyone's time here today, and I will open up to questions. I got to see if there are any in the chat or if people want to just ask them. I see there's one chat. Oh,
Yes.
thank you.